there have been a number of government-sponsored reviews as well as research which demonstrates that when it comes to reducing our life expectancy and reducing the quality of our life, there are real issues in human beings as social animals, comparing ourselves with our neighbours. And if our neighbours have better opportunities, have better material wealth, appear to be happier, we tend to feel our own lack of privilege much more acutely, and this does result in greater unhappiness and poorer health. Now, Dr. Harry Burns has synthesised over many years of observation exactly what could be the pathway for this, and I'll be very grateful for the explanation that he provides. I've seen him before, and I would highly recommend the model that he has developed. In terms of what I expect you to get out of today, we learned from the previous event which we held with GPs that yes, we've got loads and loads of data. Unfortunately, sometimes the data gets in the way. People start to get annoyed by inconsistencies or inaccuracies as they see them. We've tried very carefully to ensure that the detail is not that important, but it's inevitable that people begin to question the authority of the data. So today what we're trying to do is bring together all the stakeholders. Today what we're going to do, and I hope you've already had the chance to see the stallholders, is that we recognise that the delivery of reducing health inequalities is not any one organisation's ability to deliver. That means, I think, and I don't say this with a great deal of irony, that the voluntary community faith sector, the big society that's often talked about, will have a big role in reducing health inequalities. Local authorities also have huge interest in reducing health inequalities because they themselves are responsible for many of the factors that affect us, not just the simple things like street cleansing and maintenance of parks, but they've also got a very important role in creating jobs, encouraging new employers. They've got an important role in the quality of the housing that we live in, and because this is a two-tier area, we also have to recognise that we have both a county shire perspective, which is social services and educational services are delivered by Lancashire County Council, and there is a different breakup in terms of boroughs delivering on things like housing, environmental health, regeneration, parks, culture, etc. This makes the environment even more challenging when the government's perspective on public health is to bring together public health in only top tier local authorities, because that means automatically the assumption that public health specialists, people with specialist skills in tackling health inequalities and changing behaviour, protecting the population's health, looking at the quality of care, will sit with Lancashire County Council, and we urgently need to explore the impact of that in borough councils. Doubtless when you have the workshops you'll be able to explore some of those issues, and that is the purpose of the workshops. It is to allow different stakeholders to develop a common understanding of what inequalities means for them, and also to develop some common terminology, because we all use words differently. I challenge you to explain to each other what you mean by commissioning, for example, yet a huge element of government reconfiguration is built around commissioning. We all mean very different things by that simple word. I hope that the voluntary community faith sector stalls, and we've tried hard to get a a sort of representative sample of the kind of organisations that exist, as well as covering the 5 boroughs in as equitable manner as we can. I hope you go and find out what they can and can't do, because I think when we're going to look at important factors such as the 20% assumed reduction in spending in healthcare, QIP as it's called, quality, in innovation, prevention and productivity, or productivity and prevention, is the 20% reduction that the government expects us to make in terms of investment in healthcare. If we're going to reduce by 20% the way we use healthcare, we're going to definitely have to find alternatives to healthcare. And speak to GPs. If you speak to the majority of hospital doctors, they recognise that a significant proportion of people they see neither have the inclination, nor sometimes do they have the diseases that they're assumed to have. Obviously, from a public perspective, if I'm an ordinary individual going to my GP and the GP says there's nothing wrong, I may choose to accept that. On the other hand, if I've got a bit of education, I can browse the internet, I may well insist on my rights, and at the end of the day, the resources that are spent, quite rightly, on addressing my concerns means there are less resources for people who are perhaps needing a hip replacement. These are complex rationing arguments, and these are the sort of things that GPs will have to address in the future. However, they are all keen that this becomes an issue not just for GPs but for the public themselves, because there is a finite resource, and I believe the VCFS has an enormous amount to offer when it comes to finding alternatives to medical care, because quite honestly we can't afford to medicalise everything, and often in my experience it's a lot of the problems don't really need to be medically driven. They're often symptoms of social concerns, such as isolation, such as not having anything to do. You could be unemployed. So I think the VCFS, Voluntary Community Faith Sector, has actually got an enormous amount to offer. I think if GPs are referring to the VCFS, however, they do need to know that there is a cost. It isn't a free good, and I hope that the dialogue that takes place today broadens understanding on both sides, both GPs and the VCFS. I think there is, if one follows government planning through, an indication that local authorities, as I've said, will lead on public health. I think the consequences of that is that actually the health and wellbeing boards will become much more dynamic places, but potentially I can foresee that people will be turning round to the elected member of a particular ward, and again we've shared that data, and say, look how much premature death there was in your ward. What are you going to do about it? Don't you feel responsible? And I think that will create imperatives on them to try to get themselves much more engaged with the kind of services that are on offer and the kind of activities, evidence-based activities, that actually reduce death. Now, it's not all about death, because death is unequivocal and easy to measure, but the vast majority of us live miserably when we are disadvantaged, and we haven't as yet got a clever way of measuring that. We can measure people's unhappiness in many other ways, but the total sum of the misery and unhappiness they have as a result of deprivation is something that's difficult. In fact, there isn't really an agreed definition of deprivation when you begin to look at it, but we do understand and recognise the symptoms that lead to poor health. The fact that you smoke more, the fact that you're likely to have more risky behaviours, in total, such as drinking more, taking drugs, risky behaviours in terms of taking less exercise, being more obese than the more affluent people, not being able to do more about it, such as going to the gym. We know that employment is very protective for your health and well-being, as well as your mental health. There is a wide range of initiatives to reduce the harm from certain diseases as well, which is what the screening programs are about, and fundamentally one of the most evidence-based interventions, which is to prevent you getting the disease in the first place. Infection control, particularly vaccination, immunisation, has been perhaps the single most evidence-based intervention since the setting up of the NHS. Now obviously before then, good clean water and separation from sewerage of that water was one of the biggest innovations and had the biggest impact. I'm not going to say much more. I thank you very much for listening so attentively. I do apologise that I haven't got a snazzy presentation. We have got tons of information, so we have in your workshops made available that information, but rather not to drown out your conversations, you can visit both the stalls and there are referees in effect who you can ask technical questions from. They will be available for you during your discussions. I hope you do enjoy your discussions and make the most of this opportunity to network and to share your perspectives and perhaps devise your own strategies and your own role in helping to tackle health inequalities through the organised efforts of all the elements of society that are around you. Thank you very much.